Error. Electricity in line. Override accepted. Infusion initiated.
Welcome to the INS Infusion Room, the official podcast of the Infusion Nurses Society. In this podcast, we explore all things infusion therapy through a real-life conversation, covering the latest trends, new research, evolving standards, and key industry insights. Whether you're an experienced infusion nurse or new to the field, we aim to keep you informed and empowered with the knowledge to stay at the forefront of the profession. My name's Derek, and I'm your host. Let's dive in. Welcome to another episode of the INS Infusion Room. Today, we have special guest Suzie Eastwood joining us today, and she's going to be discussing some changes she made within her organization from the bedside. So thanks for joining the studio, Suzie. If you want to introduce yourself to our listeners, tell them a little bit about yourself professionally and where you're coming from.
Absolutely. So my name is Suzie. I am a board-certified vascular access nurse. I have experience in the emergency department. I've led nursing departments as a director of nursing. And for the last 5 years, I've worked on a vascular access team at an acute care hospital where we have made lots of advancements in the vascular access health in our organization.
And that's what we want to talk about is really the advancements that you've made as a vascular access specialist within your organization. I know that you've made some big strides, so we'll just hop right in. Tell everyone a little bit about your organization. How big of an organization are you currently working in, and how many VAT nurses do you have within your team that you work with?
Right now, we currently serve our hospitals a little over 300 beds.
Right.
We have 5 different ICUs. We do inpatient and outpatient lines, and currently we have 1 full-time person, which is me, and we have a part-time person.
Wow. So you stay very busy. And I'm talking with you before the show. I know a little bit more than our listeners right now of some of the things that you've achieved, but that's very impressive. Have heard of teams having up to 70 vascular access nurses. 70. I had some special guests a few months back in the INS Infusion Room, and they told me and they explained that they had a team of 70 to support their hospital. So we see huge variance across the board. And of course, different focuses and budgetary sources on what that looks like and the impact in which our VAT teams are really incorporating to the patient's plan of care. So thank you for sharing your perspectives. And of course, I just want to make mention that today's conversation is by no means meant to shame anyone or make someone feel like they need to have a larger team or a smaller team, whatever that may be. But it's to give perspective as to what can truly be done from the bedside. So as we dive in, you identified some changes that you wanted to see within practice within your organization. So talk to me a little bit about what you were seeing within clinical practice that made you want to see some changes initially.
Absolutely. I think for me and my personal journey, my introduction to vascular access was in the very beginning stages of COVID. I think I joined a VAT team, was my very first experience with vascular access specialty, about 8 months post COVID pandemic. And that looked a little different for me. I think during that time, organizations had to get really creative in their approach to things. Coming into a very seasoned vascular access team was a little intimidating. I had a mentor that had been iconic within our organization. She had been there for 20 plus years. She had seen vascular access in all its glory, had a ton of knowledge, been to multiple different conferences, held her CRNI and her VABC, and I was very blessed to have her as a mentor and have her lead me and develop me. So I came in at a time where there was this struggle between the glory days of vascular access and then the mid-COVID, post-COVID days of having to get resourceful and creative to meet the needs that COVID required.
And I think we can just go to budget cuts, right?
Yes. And so with that being said, I think we all can attest to the financial aspect that came along with
Yeah.
the
Big change.
ramifications,
Big
big
change.
changes, big changes. You know, I think vascular access, if your organization doesn't have a really good understanding or appreciation for it, you could be one of those first places to be cut in critical times like that. And we definitely experienced that. Personally, in my own organization, we were very blessed and fortunate to be able to keep our department, but it just looked a little different historically than it always had. We had to make changes within our organization where we actually lost our entire phlebotomy team. It's crazy. I was just recently reflecting on this, all the different
So you said
losses that
hold
came.
on. So you just made mention that you lost your phlebotomy team.
Yes.
So what did that look like whenever you lost the team? What did that entail?
So it ended up being a complete total dissolvement of our phlebotomy team, which for the vascular access specialty, we all know that typically those things are two separate entities, but they both coexist together and are very important to support each other. So, as a vascular access department, finding out that we were going to lose our phlebotomy department we were shocked because we know vascular access typically is the sibling to phlebotomy. And guess who gets referrals when phlebotomy has a difficult time? I don't know how everybody else's organization is, but ours we were the default vascular access when phlebotomy were struggling. So for us, we were already overwhelmed with advanced lines and consultations and IV referrals. In addition, adding on staffing issues and phlebotomy referrals, it was kind of scary to think what that looked like once phlebotomy was dissolved.
Wow. So lost phlebotomy. I can imagine the nurse's scope at the bedside had to really expand to meet the needs of a specialist being lost within the resource pool.
That's exactly what happened when we lost phlebotomy. The nurses at the bedside were expected to draw their own labs. And, throughout this experience post COVID, we all can attest to the fact that, not in addition to things like phlebotomy being taken away, but other resources as well, there was a lot that got removed during that time. And, to add on lab draws and take away an ancillary specialty department, it was a very difficult, challenging time for our staff.
And were you seeing any clinical changes within your vascular access devices?
We've seen a lot of patients being stuck unnecessarily multiple times
Mhm.
due to the lack of a specialist being available. So with that being said, and not having the right resources and ancillary departments, by the time you do get a specialist at the bedside, you typically find not only injuries, but maybe areas that may have been salvaged end up getting ruined by them unnecessarily being stuck.
Yeah, so vessel preservation was kind of out the window. And,
Yeah.
within the standards, I think there's a big misconception. And I've talked about this several times, but the two-stick rule, it's not, you have to stick twice before you escalate care. It's you should stick no more than two times before you escalate care or resources. And then when you're in a situation that you are needing to escalate at the bedside and the resources aren't there, then what, right? So
Right.
so I think you have a really great story about the storm and kind of really what happened there after the storm. I think the pandemic really shined lights, and I think we all had to be very adaptive to making changes. And I think during those times we thought, how can we pull through this? How can we make this a positive? How can we truly when are we going to be on the other side looking back and saying, wow, we made this through, right? But you did, right? um and from that, you really stood up to the plate. And what I really wanted to shine a light on, not necessarily the negatives, but really kind of really what you've done within your organizations. And Suzie from the bedside, as a vascular access specialist, implemented changes within her organization that not only impacted her local, but also went to higher levels, including market level, state level, in which also she then escalated into the national councils. So let's talk about that, Suzie. How did you make that happen? Because so oftentimes I hear, I'm just a nurse. I can't make change. Nobody listens to me. The executive team don't have the budget to do what I need to do. I don't have the resources. How did you do it?
Well, I think it takes a lot of grit and heart and just being resourceful. I found out really quickly all about vascular access and how we are kind of viewed systematically. It's very complex. I found out there's a lot of people when you're a vascular access nurse, we tend to forget the fact that the things and knowledge that we possess aren't common nursing knowledge or
Oh,
common medical knowledge. Um, there were many difficult conversations that I had to have with advanced practitioners, providers, bedside staff, and I found out really quickly it's all about approach. I will say that when I first joined Vascular Access, the culture can make or break a collaboration within an organization. Um, I'll say that my first introduction to vascular access, it was very, trying to find the word. It was sort of rigid. Um, Conversations were happening and collaborating with different teams that were very uncomfortable. You as a specialist, as an RN, are having to call medical directors, you're having to call surgeons, you're having to call people of various different specialties and have these conversations being the subject matter expert and give recommendations. And so with that, I found out within our organization, we weren't really respected. Um, Conversations oftentimes were coming across as confrontational. We were perceived as trying to utilize standards of practice to get out of placing lines. How many of us have heard that?
yeah.
Um, and I saw a need for education and understanding. And one of my defaults that I've always tried to do is just to lead by example and really figure out if there's a common perception or barrier, what is the root of that and how do we fix it? So, what I identified was number one, our policies were very outdated, they were very vague. And there was a huge barrier and lack of knowledge of truly what our specialty was responsible for and what we did as a department. Um, so over time, I focused on education. I had a lot of face to face conversations. I didn't rely on technology to communicate certain things to me. And with that, it allowed me opportunity to connect with people. I got to prove that I actually do possess a specialty knowledge and have a lot of value that I could bring to the organization. Working alongside the physicians and the directors and all of the administration, my approach really was to shift the focus of the vascular access nurse and the specialty as a whole as consultative rather than procedural line placers. So, through various interactions and just really being patient and lots of communication, slowly people started to shift their focus. And with that, a lot of understanding, respect came, and things have gotten a lot better.
Now, what type of resources did you use? Do you have a shared governance system, or like how did you build momentum when identifying that you needed to make policy change and change in culture for your particular department and for the specialty being represented with your department? So who did you call on? How did you make that happen? Who did you reach out for, or what resources did you use?
So initially, my approach was just the bedside interaction with the nurses, but I
Mhm.
quickly realized I'm one person And for a level 2 trauma hospital, and I'm the only full-time nurse, to remember and know who all I educated, where the barriers are, would have been impossible. So I started thinking, how do I get my voice out there? How do I get some support? I'm very fortunate to work for a magnet organization. With that, it comes various different support levels through shared governance and councils. One thing that helped me was I got involved in shared governance councils. I actually got elected as chair of a centralized council, in addition to being involved in service line councils for the critical care. That allowed me to lead and have a seat at those important tables. And what I found out out of all these councils was a common theme that kept reoccurring. We had a need for improvement in vascular access health within our organization, and it provided me the perfect platform
Yeah.
to get my voice out there and create change.
And I hear you talk about the standards and
Yes.
using the standards to guide a lot of your recommendations and validate your practice.
Mhm.
Did y- Let me ask you this. Was your policies reflective of the current standards?
I found a lot of times when we were getting into situations and we were presenting standards of practice, they didn't align with policy. So I dug into our policies and I identified they were very vague. They hadn't been updated in a while. And so I made it a mission to reform that. And
Mhm.
so I ended up getting involved in state and national levels of policy reform.
Well, do you think it was a
And
domino effect? You start local and then the
yeah,
word gets out that you're working on something, and then you get recruited to this. I mean, is that kinda how you felt? I know in my past, that seems to be kinda how it worked. It's word of mouth and just one thing leads directly into another. It's just like, once you open the gate, it's just a big flood of opportunity, really.
sometimes it's just divine intervention. I feel for me, um, I saw the need and it was something that was heavy on my heart. Oftentimes, we as vascular access nurses, we try to approach complicated situations that we know in our specialty could have a poor outcome. But when you go up to providers and, administration and you have concerns as a specialist, they don't understand the specialty, and when you come with the standards of practice, it's like it's foreign material to them. Finding time for someone to really sit down and give you the attention that you need to explain what our standards, it can be very challenging sometimes. So I made it a mission to include those in our policies.
That's wonderful, and sometimes I know working within the specialty myself, sometimes providing the standard wasn't enough. They want to know the rationale for why the standard was created. They want to know every document supporting that. And there's a lot of discussions that you have to really validate beyond that. And that can be very intimidating to some clinicians. Can you weigh in on that?
Absolutely. There's been days where I've got this number of standard, and they would have questions about it. So then I might be running over, printing out something from the CDC, and then I might be running over and printing something out from the oncology journal, or, it's just such a complex realm that to me, I just felt like if I can simplify this and put it into literature that people know, what better place to
Policy.
put it
Yeah.
into your policy?
Yeah.
So, also for me too, coming into the vascular access world, I've always looked at it as, what do I need to know if no one's around? I need a resource where I can go directly to that one resource and know exactly what I'm supposed to be doing and what I do in this situation. So it was important for me to include those things in policy.
So You got on the policy team, and then you transitioned quickly into higher policy teams, including national policy. What was that like? Had you had any
Wow.
experience doing that before?
Um, no, actually, I joined the National Vascular Access Committee for our organization, and I was a little intimidated at first, but I quickly realized that it was just a bunch of brilliant, like-minded people, and I never felt so supported and comfortable. As a vascular access specialist, sometimes you feel like you're always in question, where you always have to prove your knowledge and what your specialty. And it was so empowering and so impactful to be on a call with people from all over the nation in your organization, and you all have the same opinion and you
Yeah.
all have the same mindset because you all believe so highly in the standards of practice.
You found your people at that
I
point,
found
right?
my people. Oh my goodness, I can't describe how amazing it was. And then the very next phone call, the next virtual meeting that we got on was there was a extravasation policy that pharmacy in collaborations with some physicians wanted to roll out nationally. And they gave us the policy that they were going to submit a few weeks in advance, and we were asked to review it. And when I was seeing things like vasopressors ran through peripherals
Oof.
and um, through
Barb Nick,
midlines even.
Barb Nickel, close your ears.
Yes. Um, there was literature from, studies of vasopressors being ran through
Yeah.
midlines, and I cringed, I was terrified that if we don't stop this,
Yes. It's a
so
real issue.
yeah, so it was intimidating, but the moment I got on the call, within the first 3 paragraphs that we were reading through as a team, someone spoke up. I was very new to this council, this committee, and someone spoke up and said, "This isn't safe. I would not put my stamp on this, and until they come back with safer practice, then I'm not going to be in agreement for this." And then it was like everybody kind of breathed a sigh in relief. And we said, "Well, if everybody's in agreement, there's no need to further this call. We're not gonna give our blessing on this." And so it was very reassuring to know that and feel confident in my practice.
And you actually wrote some policies involving vascular access devices and infusion therapy for your large group too. Talk about what
Absolutely.
that was like when you finished that.
Well, it was scary. I actually ended up becoming the subject matter expert within the different work groups. Our policy began as a market statewide policy that included all vascular access devices, and it was very vague, didn't have a lot of detail in it, and it just really didn't feel like a good resource for our bedside staff. From there, we were tasked with breaking up all these different work groups. We ended up separating the policy into a peripheral policy and a central line policy. And then it began the discovery of, okay, this is what the bedside staff needs to know. But what about vascular access specialties? We need our own policies that aren't even pertinent to the bedside staff. So 3 more work groups spun off of the original work groups for vascular access insertion specific policies, where we developed a ultrasound guided peripheral policy, a midline policy that we never insertion policy that we didn't even have before, and then reforming the PIC insertion policy for vascular access.
What kind of response did you get whenever those rolled out?
I would say the most popular opinion that people had towards the new standards of practice were, "We've never done things this way in my entire career or years of service in vascular access." People just are they get intimidated by change.
Mhm.
For me personally, I feel like that was what a lot of it was. But it was important for me to meet them in that moment and relate and say, guess what? This is going to be a change in practice for our organization as well. But this is what evidence base shows and proven for best patient outcomes and what's safest. So we're going to do it. And once you spin it like that, it's hard to argue with what's best for patient outcomes and what's safe, and what's been proven by evidence based practice.
Absolutely. It is. And when you have the evidence, you can't deny it, right? So even though they shouldn't be able to argue, I'm assuming that you did have a few one-offs. Any fun stories?
I think the biggest challenge so far has been the ultrasound IV insertion policy. Histo this is this is such a sensitive topic, and I can't tell you how many hours I've spent on research and lit reviews and education, one-on-one meetings to explain the why. I just didn't realize a sterile probe cover and a CHG dressing would be cause such an uproar. Um, when I first read about it, I was like, "Man, this is great. This makes so much sense." And, you know, I was excited because I understood the why. But I didn't really think about how this would be perceived not having the literature first. So, I got a lot of fun calls from people across the organization, from other hospitals that work in procedural departments, including emergency rooms. Um, they were not happy with me. I actually had people cross paths with me from our own local hospital and say, "I'm mad at you."
Oh,
Um,
goodness.
so it was very, very fun, very colorful. But it provided a very good opportunity and gateway to get some much needed education and literature out there for safe practice. That's mainly what was important to me. Who's going to listen to little old me?
Oh, apparently a whole nation.
Yeah, I guess so. Um, but yeah, another thing that was really beneficial for me was collaborating with vendors. We have a really great vendor that we partner with, and they provide tons of resources, education. They actually would come in and survey our vascular access health and management within our organization, and that was equally crucial for being able to have the tools and resource to present. I think that was my driving force. It's such a respectable specialty and brings so much value to an organization, but they have to see it. Your
Yeah.
organization has to see it, and they have to respect it, and they have to value it. And when I first joined my vascular access team, I didn't feel like that those things existed, and it was challenging. So I made it just my mission over the last several years to try to shift that culture and that focus. And
And
we're like,
you've added some credentials to the back of your name over the past year, right?
I have, yes. I currently hold my VABC. I am in the process of studying and prepping for my CRNI. Um, that's that one
That's
I'm
exciting.
so excited for. But I did it this
Congratulations
way.
on the VABC too.
Thank
What
you.
did that do for your
Um,
practice, getting certified?
wow. Well, number one, studying for my practice in my practice, studying for it changed my practice. I remember telling people, "Oh my gosh, I do this." Um, had no idea you weren't supposed to hub a PICC line. Um, there is definitely a much needed certification, brought a lot of value and improved my practice tremendously. Um, it was important for me to get my VABC as the specialist for the hospital, because I wanted to truly know and feel confident that what I was doing and saying um, was the aligned with practice.
Absolutely. And then what's driving you to do CRNI now?
Just further advancing my clinical specialty. It's CRNI to me. It exemplifies what vascular access nurse is, and I feel collaborating both, connecting both VADC and CRNI. It's just it exemplifies what a vascular access nurse is. So
Absolutely.
it's extremely important to me.
Well, thank you for your contributions to the specialty. I know that a lot of listeners right now can relate with your story and can appreciate all the efforts that you've had within making strives for the patients and the specialty as a whole, as a specialty, not just a skill in which sometimes we're viewed. Thank you again. And as we wrap up today's episode, do you have any final key takeaways or advice you want to give to someone who's working through a difficult change within their organization?
Never forget your why, and always put the patient first. That oftentimes gets lost. And I think if we can put the patient at the center, then we can never be wrong.
Yeah, go ahead.
And I highly recommend adding those credentials to your name, speaking from not having them to now working on them. The overall process has just fully advanced my practice, and I highly encourage everyone to pursue those credentials. They really are worth it. And beyond having those initials after your name, it really is going to make you a better specialist.
Well, thank you, Suzie, for being a guest today. We really appreciate you. And as always, I'm your host, Derek, and it's been a pleasure sharing this important discussion with you. Remember, knowledge empowers us to make informed decisions. Until next time, stay informed, stay curious, and keep gaining knowledge. Thank you for tuning in.
Infusion complete.